Which of the following is true regarding hypokalemia? A. Patients with a recent myocardial infarction, MI, are at increased risk for ventricular arrhythmias if the potassium concentration is less than 4.0 MEq per L. B. The presence of U waves and ST segment depression on electrocardiograms, EKGs, correlates with the severity of hypokalemia. C. Neurologic problems are the most common manifestations of hypokalemia. D. Vomiting or nasogastric suctioning may lead to profound hypokalemia. E. Potassium is the most prominent extracellular cation. The answer is A. Patients with a recent myocardial infarction, MI, are at increased risk for ventricular arrhythmias if the potassium concentration is less than 4.0 MEq per L. Answer A. Hypokalemia is more common and generally better tolerated than hyperkalemia. Diuretic therapy is the most common cause. Hypokalemia primarily affects the cardiac, arrhythmias, musculoskeletal, weakness, rhabdomyolysis, GI, ileus, and renal, nephrogenic diabetes insipidus, metabolic alkalosis, systems. Neurologic manifestations are not common. Cardiac dysrhythmias are the most serious complication, although patients without pre-existing heart disease rarely have any complications. In contrast, patients with acute or recent MI may develop ventricular fibrillation in the setting of even mild hypokalemia, 5 times increased risk if the potassium concentration is less than 3.9 MEq per L. Therefore, recent recommendations are to maintain serum potassium levels greater than 4.5 MEq per L in such patients. The number or degree of EKG changes does not correlate with the severity of hypokalemia. Neither vomiting nor nasogastric suctioning causes significant potassium loss. Potassium is the most prominent intracellular cation, while sodium is the most prominent extracellular cation. In an acute NSTEMI, which of the following advantages does bivalirudin possess over unfractionated and low molecular weight heparins? A. Improved mortality. B. Lower incidence of major bleeding. C. Lower rate of conversion to AST elevation myocardial infarction, STEMI. D. Increased anti-10 activity. E. Increased anti-13 activity. Answer B. Lower incidence of major bleeding. Answer B. Bivalirudin is a direct thrombin inhibitor, which is a synthetic analog of hirudin, a protein originally extracted from leeches. Both drugs are direct thrombin inhibitors that do not require antithrombin 3 activity. Although bivalirudin also inhibits platelet aggregation, it does not cause thrombocytopenia, which can be associated with both unfractionated heparin and low molecular weight heparins. However, in contrast to hirudin, its principal benefit is a decreased rate of major bleeding, particularly among patients who are considered to have an increased risk of major bleeding. Bivalirudin is the recommended drug of choice by the AHA for patients with NSTEMI undergoing an early invasive percutaneous intervention, PCI, and for patients at increased risk for bleeding who are undergoing immediate PCI. Fondaparinux, enoxaparin, and unfractionated heparin are the preferred agents among patients with NSTEMI not undergoing PCI, conservative management. Which of the following is the most common arrhythmia in patients with pulmonary embolism? A. Multifocal atrial tachycardia. B. Sinus tachycardia. C. Atrial fibrillation. D. Sinus rhythm with atrial premature contractions. E. Ventricular fibrillation. Answer B. Sinus tachycardia. Answer B. The chief use of EKG in the evaluation of patients with a suspected PA is to rule out the presence of other causes of chest pain such as myocardial ischemia or acute MI and pericarditis. Numerous EKG findings have been reported in the setting of acute PE, although S1Q3T3 is perhaps the most famous. Several papers have reliably refuted the utility of this finding. S1Q3T3 was first described in a 1935 study of 7 patients who all likely had massive pulmonary embolus. Similar studies have all been plagued by a selection bias for patients with large or massive PE. Several EKG findings are more specific in patients with massive PE, but other clinical signs and symptoms, example, hypoxia, dyspnea, tachypnea, and chest pain, are typically more useful than EKG. Which of the following is true regarding the MB fraction of creatine kinase, CKMB, in acute myocardial infarction, MI? Starts elevating 1 hour after MI. B. Peaks at 36 hours after MI. C. Returns to baseline within 72 hours. D. Sensitivity at 3 hours after MI is 95%. E. Specificity at 3 hours after MI is 95%. Answer: C. Returns to baseline within 72 hours. Answer C. The MB fraction of creatine kinase is present mostly in cardiac muscle, but also in small quantities in skeletal muscle. Levels of CKMB begin to rise between 3 and 8 hours after infarction, peak at 12 to 24 hours, and return to normal within 3 days. Neither the sensitivity nor the specificity of CKMB at 3 hours after acute MI is greater than 50%.